This conference will now be recorded.
Um, Good morning. Good morning, everybody. It is 95 and counting. Okay. Shall we start the session?
Yes, sir.
Shall we? Yeah, Pavan. Yeah, we're starting. Okay. Today's topic is another endocrine uh, disorder, and which is most common. We did diabetes mellitus previously, and today is regarding thyroid disorders, which constitutes both hypo and hyperthyroidism. Hypo being more common. And yes, this differs from adult population because hypothyroidism in pediatric age group and in kids and even as small as neonates, uh, that can be detrimental and that can sentence them for cretinism for life. So uh, the importance is more in case of hypothyroidism in case of children. Okay. And hyperthyroidism also is a serious disorder, and yeah, and also in neonatal thyrotoxicosis can cause mortality of good percentage of 10 to 20%. So even that is of some significance, but it is relatively rare compared to hypothyroidism. Okay. Yeah. Now coming to the topic. Now we'll do from anatomy. Just brush up our previous no knowledge. Okay. Coming to the anatomy, thyroid gland derives from the floor of embryonic pharynx, begins to develop around 4 weeks of gestation, and moves down the neck following its characteristic bilobular structure. Okay. And the development is mostly completed by 10 to 20 weeks of gestation, and your thyroxine that is being produced, it can start, the fetus starts producing thyroxine from as early as 9 to 11 weeks of gestation. Okay. So that says that it gets the development gets completed by as early as 10 weeks, because thyroxine hormone in fetus, it is like a growth hormone, and it will aid the fetus to grow both maturation and development. Okay. Both in functional and also in growth of the body. So that is important. So it comes early in the gestational age. Okay. Thyroid gland size increases gradually by 1 gram per year, and it grows till 15 years of age after birth, and the adult size is around 15 to 25 grams. Okay. Yeah. Then this is the big the clarity is not so good, but yes, I'll describe it. This is from the floor of the pharynx, the development of the thyroid, and if there is a remnant and tissue has been uh, failed to come down, trickle down over the development, if it stays there, it will become a lingual thyroid. And then during the tract, if it gets stuck here, it is the hyoid bone, and if it is above the hyoid bone, it is suprahyoid thyroglossal cyst. And if it is near the cricoid cartilage, it is thyroglossal cyst, or the normal ectopic thyroid, which we normally say. And then this becomes the pyramidal lobe. Pyramidal lobe is the pyramidal structure of the gland. Okay. From at the isthmus. Okay, this is the normal position of the thyroid, and thyroid can also be present beyond beneath the sternum, and it is called retrosternal goiter, and it can produce, and it can be confused with the thymus, which is normally present there. Okay, this is just of anatomical and embryological significance, so that anywhere the thyroid can be stuck. If the thyroid, if we are unable to palpate it in its normal location, don't worry, we may have to go all these tract and identify it. Okay, this is the place where our thyroid scan comes in aid, and will identify where the thyroid is. Okay, whenever you're suspecting an ectopic thyroid which is not in its normal position, if it is somewhere else, so that is when we'll get this scan done, thyroid radio isotope scan, so that we'll know the location of the thyroid where it is situated. Okay. Now, coming to the gland per se, it normally secretes mainly T4 and some amount of T3, and 70% of T3 derived from T4 in the peripheral tissues, and T4 is converted to T3 by 5-deiodinase enzyme. This is all physiology, and both T4 and T3 are bound form with thyroglobulin and prealbumin and albumin. And for all practical purpose, T4 is the most active form. And what we talk about thyroxine and thyroid gland and the thyroid hormone is T4. Okay, T3 is of less significance. It is of not much importance as such in its function. Okay, yeah, free hormone concentration best correlates with the thyroid status. So always try to advise free T4 and free T3 than just T3 and T4, because these bounding forms like the thyroglobulins and prealbumin and albumin get interfered with the normal value of the thyroxine. So it's always better to go for a free T3 and free T4 whenever you're advising along with TSH. Okay, T4 production is 5 to 6 micrograms per kg per day in infancy, with the gradual decrement to 1.5 microgram per kg per day in an adult. Okay, remember this, T4 is more in case of infancy, because thyroxine is more required in case of infancy because the child grows. Okay, thyroxine is a hormone which aids in growth and development. So in infancy, where it is most needed, it is mostly produced. Okay, 5 to 6 mic per kg per day. As in adults, it is only to maintain the metabolism and metabolic rate and few functionalities, which we'll be discussing later. So the demand comes down, so the production 1.5 mics per kg per day. Okay. Now, coming to the effects which we are discussing, the effects of thyroxine, what does it do to the body? It is the fetal brain and the skeletal maturation. As we discussed, it is like a growth hormone for the baby, for the fetus, and increase in metabolic basal metabolic rate, inotropic and chronotropic effects on heart. It increases the contractility and also the rate of the heart to pump more efficiently, and increases sensitivity to catecholamines, which also aid in the pumping of the heart. And yeah, stimulates gut motility and yeah, for the normal gut motility, and increase bone turnover, and increase in serum glucose, decrease in serum cholesterol, because it is like a more working out, it's just like exercise. So it decreases the serum cholesterol, and conversion of keratin to vitamin A is a function of thyroxine. This is important. Just remember, this is for the entrance. The keratin to vitamin A, this is one of the functionality of the thyroid hormone, and it plays a role in thermal regulation to maintain the normal euthermia of 98.6 Fahrenheit degrees. Okay, these are the functionalities. And coming to the topic, one of the topic per se, hypothyroidism, it is most common, and can be classified into two different types. It is whether it is congenital or acquired, and yeah, uh, in case of primary hypothyroidism, it is congenital or acquired. In case of secondary hypothyroidism and tertiary hypothyroidism. So what is this primary, secondary, and tertiary is? Just remember, whenever in endocrinology, whenever somebody says that it is a primary disorder, whenever says that it is secondary disorder, what they mean is primary disorder is the organ as such. Okay, if we are talking about thyroid, primary hypothyroidism means the organ itself is been damaged. And now what happens to a secondary hypothyroidism means, the secondary means it is not the primary, the tissue, the organ is good, but something else that is been influencing is affected. Most of the times it is a pituitary. Okay, secondary is mostly the pituitary disorder. And what happens, the tertiary is to the higher, to the hierarchy, it is hypothalamus. Okay, that is your tertiary disorder. Okay, just remember this. Even be it adrenaline, be it thyroid, whatever, this primary, secondary, and tertiary, the nomenclature is based on the organ of involvement. Okay, yeah, coming to the primary hypothyroidism, it can be classified in two different forms. It is congenital and acquired. As the name suggests, congenital from birth, and acquired is the child contracts in between. And coming to the secondary hypothyroidism, it is hypopituitarism. As we discussed, the pituitary got hit, will be getting hit, and the disorder is from the center. And the deficiency of TSH, which is a product of pituitary gland, and it is in case of tertiary hypothyroidism or tertiary disorder, it is the hypothalamus which doesn't produce your thyroid releasing hormone, TRH. Okay, I think you are with me, right? This is the classification and how it goes. Yeah, why is it not? Yeah, coming to the congenital hypothyroidism, yes, this is your of clinical importance, mostly of clinical importance than theory, and your examiner may be fantasized in asking you questions regarding hypothyroidism. Yeah, it occurs in about 1 in 4,000 live births, and the thyroxine is important for CNS development and postnatal growth. As we discussed, it is good for the brain and the physical growth also. The most frequent cause is absence of the gland. As such, the gland doesn't exist. Okay, that is the most common occurrence. That is athyrosis. That is for athyrosis. Thyrosis, thyroid gland, athyrosis. There is no thyroid gland. Okay, that is the most common cause in case of congenital hypothyroidism, and the presentation may include cyanosis, prolonged hyperbilirubinemia, and actually the disorder may be found if the blood test is not being done properly, if the newborn screening is not done in cases of any remote or home delivery kits. The child will come with prolonged jaundice. Actually, the jaundice which is not coming down. That is how you see a child uh, for the presentation from the mom. Okay, then you go retrospectively and do the blood routines with the thyroid, and maybe you will find an elevated TSH and find that it is your hypothyroidism that is causing your prolonged hyperbilirubinemia. Okay, and poor feeding, hoarse cry, umbilical hernia, respiratory distress, macroglosia, large fontanelles, and patent fontanelles, and delayed skeletal maturation. All these are features of your congenital hypothyroidism. We will be discussing the symptoms subsequently. And rarely neonatal hypothyroidism is transient. Yeah, there is something called transient hypothyroidism where there is the TSH is elevated transiently, and then it gets corrected within few weeks. Okay, that is one uh, entity. Okay, yeah, coming to the etiology of congenital hypothyroidism, as we discussed, it is most commonly your thyroid dysgenesis. You know that the thyroid is not being formed properly. The main organ, the gland itself is got hit. So that is where the main problem lies. That is mostly the genesis is not there. Okay, mostly it is idiopathic. Nobody knows why. A few genetical causes and a few HLA association, whatever it is, but it is mostly idiopathic. Nobody knows why it happens, but there will be no thyroid. Okay, the commonest cause in 95% of the cases is dysgenesis. There won't be any thyroid, like athyroidosis, like in 40%, and hypoplasia. Thyroid will be there, gland will be there, but it's very small and insignificant in existence. Okay, and ectopic thyroid also comes under dysgenesis. It lies in this is important, remember, ectopic comes in dysgenesis. Okay, the formation is a defective. Either it is absent, or it is not in the place where it is should be, or it is not in the size where it has to be. Okay, that is athyrosis, hypoplasia, and ectopia. Okay, all these constitutes your dysgenesis. Okay, the classification is important. You can't put ectopia in dysharmonogenesis. Okay, yeah, this constitutes most of the cases, 95% of the cases. The rest of the cases, the next common cause, or the other thing of considerable significance, is your dysharmonogenesis. As the name suggests, the hormonogenesis, the thyroid formation is a defective, be it because of any receptor defect, or any uptake, iodine uptake defect, or any globulin defect. Whatever it is the hormone is not getting processed. The thyroid gland is present at good size, at its normal location, but it is not producing the hormone, whatever the cause be. That constitutes your thyroid dysharmonogenesis, which is mostly autosomal recessive and constitutes around 10% of the cases of hypothyroidism, congenital hypothyroidism. And next, which is rare, coming to the rare causes, it is a hypothalamic and pituitary hypothyroidism, where the pituitary and hypothalamus are got hit, like your brain as such, the formation defects like anencephaly, holoprosencephaly, and septo-optic dysplasias. These are all anatomical defects and malformations where the gland itself is being distorted and not formed. So obviously it doesn't produce your TSH and TRH. Okay, and always there is idiopathy. Okay, this is your basically, just don't forget dysgenesis, thyroid dysgenesis, and dysharmonogenesis. If you do this, you have already covered 98% of the cases. Okay, yeah, coming to the transient hypothyroidism, which we discussed earlier, in neonates there can be transient hypothyroidism. The cause may be maternal antibodies, thyroid receptor antibodies, which have been which the newborn must have acquired from the placenta, and maternal ingestion of goitrogens. So these effects will last for only few days, and the normal thyroid present in the newborn will take over the functionality, and subsequently the hypothyroidism goes off. That is the concept behind transient hypothyroidism. And yes, drugs taken by the mother and drugs given at an ICU can cause hypothyroidism. Iodine excess or deficiency causes overburdening and less fuel for thyroid and causes hypothyroidism. All these are the causes that have been enumerated. And now coming to the presentation of congenital hypothyroidism, what happens to the newborn? How do you look at the newborn, and how do you identify it, or what are the features that you are going to look for when you have hypothyroidism in the mind? Okay, it is macroglossia. It is the enlarged tongue because of the accumulation of mixed edematic tissue that causes your macroglossia, and prolonged hyperbilirubinemia because the basal metabolic rate has been hit, so that the metabolism of the jaundice, excretion of the bilirubin is getting hit, so there is hyperbilirubinemia. And poor feeding, lethargy, poor feeding and coarse cry, decreased activity, and constipation, as we discussed, the peristalsis gets hit, and so the constipation. And umbilical hernia, the weakness of the abdominal muscles, and yellow dry skin because of the accumulation of the myxedematous tissue over the skin, and large fontanelles and patent fontanelles don't get closed because skeletal maturation is the functionality of thyroxine hormone, and when thyroxine hormone is deficient, your skeletal maturation gets hit. Again, delayed skeletal maturation, as such the growth gets hit. Okay, all these are features of congenital hypothyroidism. Okay, now coming to the, yeah, we'll do the treatment later. Coming to the acquired hypothyroidism, as we discussed, acquired, as the name suggests, during the course of the disease, the child must have uh, got antibodies or somewhere from the uh, disease per se, or the antibodies produced by the baby, that will cause hypothyroidism. It's more common than hyperthyroidism. Actually, the incidence goes like this: congenital hypothyroidism, then goes acquired hypothyroidism, then the incidence is hyperthyroidism. Hyperthyroidism is a relatively rare condition in case of pediatric population, but yes, they do occur. But they're rare than what happens in the adults. Adults, hyperthyroidism you can see now and then. Okay, yeah, in 99% it is primary. As we discussed, primary means thyroid gland as such that is involved. Okay, and less than 1% due to TSH deficiency, that is your secondary, your pituitary. And pituitary has a tumor or adenoma that will produce more TSH, and that will stimulate more thyroid, and that will stimulate more T4 for production, and T4 gives you the symptoms. Okay, that is how your acquired this thing. Okay, okay, and most commonly it is the Hashimoto's thyroiditis, most common thyroid problem in 4% of the population, and most common cause is iodine, most common cause in iodine depleted areas. I mean, if there is no deficiency of iodine and there is good iodine in the population, I mean, in the surroundings and in the diet, and if that the population is having hypothyroidism, the most common cause is your Hashimoto's. Okay, and it is a chronic lymphocytic thyroiditis, and this is our pathology actually, yeah, associated with antibodies, like peroxidase antibodies, thyroxine peroxidase antibodies, and less commonly globulin antibodies. Iatrogenic hypothyroidism from radioactive iodine therapy can also be present, and that is also constitutes your acquired hypothyroidism. Okay, few other causes of interest is subacute thyroiditis. As the name suggests, it is thyroiditis. There is inflammation of the thyroid gland which is causing the hypothyroidism. But the one interesting fact regarding hypothyroidism, subacute thyroiditis, is it both presents in hypothyroidism and also your hyperthyroidism. It has both constituents. So, initially, it is present with hypothyroidism with the decreased production of thyroxine hormone, and then subsequently the patient develops hyperthyroidism. Okay, this is something important. And what are the features of subacute thyroiditis? Is painful, often radiates to the ear. As the name suggests, you just remember it is itis. So all the signs of inflammation will be present, like your redness, pain, uh, and obviously there is why the redness and inflammation, maybe the infection. Okay, so remember like this so that it will be more easier for to make a note, or you can read it or remember better. The subacute thyroiditis, it is painful, often radiates to the ear, complaints of malaise, pharyngitis, fatigue, fever. Yeah, as we discussed, infective cause, so fever, fatigue, pharyngitis, neck pain, swelling, all the inflammatory signs. Okay, and the most common cause is viral etiology, either a upper respiratory tract infection or pharyngitis, and it is usually self-limiting. Like most of the viral infections, it is self-limiting. And treatment of inflammation can be done with salicylic acid. Sorry for the abbreviations. Don't do that in your exams or your any writing. Yeah, inflammation with aspirin or NSAIDs or steroids. In case of severe cases, we can use steroids to decrease the inflammatory pain or the inflammatory process. Okay. Another cause is suppurative or acute infectious thyroiditis. As such, there is infection to the thyroid gland like any other gland. Thyroid, if it gets infected, which is usually rare, but usually bacteria gets infected more than fungus, and mycobacteria or parasitic infiltrations can be there. And patients are acutely ill with the painful thyroid gland, just like an abscess sitting in your thyroid. This how bad it is. That is how they present. Okay, in case of infective, this is rare actually, but as to enumerate the causes, we have to make a note of it also. Okay, viral cause causes subacute thyroiditis, and actual the bacterial cause or any fungal mycobacterial cause that will produce you suppurative or infectious or an abscess of the thyroid gland. Okay, which is usually again like any other infection or any other abscess, it causes fever, chills, anterior neck pain, swelling, dysphagia, dysphonia. Okay, that is common sense, right? Yeah. Yeah, coming to the symptoms, how acquired presence. Okay, a normal growing and active child gets generally slowing down of things. Activeness comes down. He becomes lethargic and somnolence is more sleepy, and he finds mom finds the baby to be more depressed and isolated, not active and attractive to the family and friends, and modest weight gain, and he'll be gaining weight because of accumulation of more myxedematous tissue. And there is cold intolerance and hoarseness of voice. Hoarseness of voice is again because of accumulation at the vocal cords. Okay, that causes your hoarseness of voice. Dry skin and constipation, as we discussed. Constipation is a symptom because of decreased peristaltic activity, which is a function of thyroxine, and general aches and pains like myalgias, arthralgias, which gets worsened with cold temperature. Okay, at nights if it is getting bad, or yeah, at nights if it is getting bad, or at winter season if it is getting very hard for the child to move around or having more pains, we may have to think about thyroid. Okay, hypothyroidism. And brittle hair, weak and brittle hair and easily pluckable hair, and menstrual irregularities in case of adolescent females where there is excessive bleed or a failure of ovulation, and decreased libido, the drive. Okay, these are the symptoms. And on examination, it is dry skin, pale, coarse, and yellowish tinged, and periorbital edema will be present. This is because of the accumulation of the inflammatory substances because of antibodies that are present, and puffy face and extremities, and sinus bradycardia, because as we discussed on the cardiac involvement, it is inotropic and chronotropic effect on heart, which is lost because of hypothyroidism. So there will be sinus bradycardia, diastolic hypertension. This is important again. There will be diastolic hypertension because your systolic doesn't produce much of this thing, and the peripheries gets more clumped up with the accumulation. So the arteries gets more compressed, edematous and compressed. So there will be diastolic hypertension. The peripheral vascular resistance increases subsequently. So there will be diastolic hypertension. And there is decreased body temperature because basal metabolic rate gets decreased, so decreased body temperature, and delayed relaxation of reflexes. Megacolon, because the colon gets distended because of decreased peristaltic activity. There is more fecal matter that gets accumulated, and the colon gets distended. And there is pericardial and pleural effusions, and congestive heart failure. Non-pitting edema, non-pitting because it is not the fluid that is accumulating, it is the as such myxedematous tissue that is getting accumulated beneath the skin. So you don't get the pit, but you will find that the glossy contour will be there, but there won't be any pitting of your extremities. Okay, coarse voice and myopathies. Myopathies is because of again accumulation and deposition of tissues in the muscle. Okay, that will cause muscle pain. Okay, coming to the diagnosis, how do we diagnose a case? of congenital hypothyroidism or acquired hypothyroidism is to run investigations. Normally we do newborn screening after 72 hours, because till 72 hours you may find your TSH and T4 from the mother, which gets transmitted from the placenta into the newborn. So we don't want mom's thyroid, so we'll wait for 48 to 72 hours, so that to find that what the baby is producing. The normal newborn screening, this is universal and it is mandatory, we have to do it, because the importance is, if you identify it early, if you substitute with thyroxine hormone, you will prevent mental retardation, and you will prevent growth failure, you will prevent a lot of burden to the family and to the baby. Okay, a lot of mortality and morbidity. So the importance is of paramount nature. Like, you have to do it, and you are not, we can't afford losing a case of hypothyroidism in a newborn. Okay, it is that important, because it is one of the most preventable cause of mental retardation, and you can make change. Okay, that is why in congenital hypothyroidism you just go for a screening of TSH and free T4. That is ideally, but plain TSH will do the job for you. If TSH is elevated, that means that your thyroid hormone is not proper, and so may have to supplement your thyroxine. Again, thyroid scan in case of congenital hypothyroidism is because to identify whether the gland is present, or the gland is ectopic, or the gland is good and the production is defective. This is dysplasia or dyshormonogenesis, whether the hormone is not getting produced properly, or the gland itself is not working. Okay, that is what your thyroid scan helps you with. Okay, now coming to the acquired cause. Now at the time of birth, everything is fine, the child is okay growing, and somewhere around the childhood he found he'll be finding it having decreased activity and hoarseness of voice, gaining weight, and constipation. That is how they present. And then in such cases you do your TSH and free T4, and you may have to look for antibodies, because the gland must be there, the growth is good and everything was normal previously, and now the child got hit with growth and all these things. So there is something that has occurred in meanwhile. Okay, so we are going to look for thyroid antibodies and thyroid ultrasound. Okay, because to find out any abscesses or any solitary nodules or multinodular goitis and all this stuff, so we may have to go for an ultrasound. And remember, TSH, as we discussed, if TSH is low, it is low in secondary hypothyroidism. TSH is produced from pituitary, and secondary hypothyroidism is the cause of a pituitary. Okay, and it is high in primary. Primary is thyroid. Okay, if the thyroid is defective, so TSH will be high. And yeah, 95% of the cases it is because of the dysgenesis, dysplasias, and this thing. So TSH will be elevated. Okay, and if thyroxine releasing hormone test, it is used in the differentiation of a secondary and tertiary. We discussed, right? If TRH is low, the hypothalamus itself is not producing. That is your tertiary cause. But if TRH is high and the thyroxine is low, that means your pituitary got hit, and the pituitary is not getting stimulated by TRH, because the pituitary is defective. Okay, that is how you differentiate between secondary and tertiary with TRH, and primary and secondary with TSH. Okay, this is how the diagnosis goes. And there is one constituent in between, that is Euthyroid sick syndrome. As the name suggests, sick syndrome, whenever the child gets sick because of the inflammatory mediators, there will be some decreased thyroid activity. Okay, abnormalities in thyroid function tests observed with the systemic non-thyroidal illness. Maybe the child is having fever, maybe the child is having any dengue or other symptoms. Okay, but during this period, the thyroid function tests are found to be abnormal. Okay, after the resolution of the illness or after the resolution of the condition, there will be subsequently decrease and normal functionalities. Okay, so that is the reason why we don't do thyroid estimation in ICUs, because during acute illnesses the thyroid hormones are expected to be haphazard. Okay, so we are not going to do that. So once the things get settled and everybody gets fine, only then we are going to look for thyroid. Okay, yeah, it is cytokine mediated and reduce TRH, release TSH response, and T4 production or release, or T4 T3 conversion, and globulin production. All these reduced abnormalities can result in euthyroid 6 syndrome. As the name suggests, you just remember 6 syndrome. Don't get confused. The child is sick so that he is having some having some thyroid abnormalities. Okay, so that is how, when asked, you just make up a question. Okay, this may be your short note actually. Okay, there is increased somatostatin secretion, which is somatostatins are your inhibitory hormones. So there is increased secretion, and the inhibitory effects of dopamine and glucocorticoids and TRH. All these things are the cause why result in your 6 syndrome. Okay, and there is very low T4 values have very poor prognosis. Okay, if it is getting hit more, the prognosis is bad. Okay, usually once the illness comes down, it gets better by itself. Okay, but rare causes, when the T4 is really low, then the child is in soup. Okay, now coming to the treatment, you have done your routines treatment. See, identifying is difficult. See, 95% of the case the gland itself is not there, or the gland itself is somewhere else, so not much we can do with any medication. Okay, so then evaluation. Okay, if the gland is not there, there's nothing we can do, so we have to supplement from outside. So the main stay of the management is levothyroxine replacement, and it should be started as early as possible, because time is development there. Okay, in case of pediatrics, time is development. If you are delaying it by few weeks, like if the treatment is started more than a month or 2 months of age, more than 95%, 75%, there is a risk of hypothyroidism development and the child going for mental retardation. So it is as early as possible. So it is a race against time. Within a week, the guideline says that within a week of life, you should identify that hypothyroidism. You have to supplement with hypothyroxine within a week of life. If it is prolonged by 2 weeks, 3 weeks, it is time. Once time lost, the brain gets affected, and there is some amount of neurocognitive disorder that will be present invariably when the child is growing. Okay, if the treatment is delayed. Okay, so this is of importance. Okay, one of the say, on the other hand, delayed treatment of hypothyroidism will lead to advanced skeletal maturation, synostosis, and intellectual defects. This is something regarding hyperthyroidism. We'll discuss it later. And levothyroxine is the main drug for treatment of hypothyroidism, whatever the cause may be. Okay, just remember that there's not many drugs. There is only one drug, very easy to remember and very easy to associate with. Okay, yeah, these are the few pics naturally taken. These are the cases which you will see. This is here macroglossia with protruding tongue, and the baby is lethargic, closing eyes, not very active. Okay, this is how a cretin, a hypothyroid disorder presents with. Okay, this is another case with coarse features of the face and forehead hair, and this will cause this is another picture of how it presents. Okay, there is some fancy term called cubic square. Is cubic scoring. Just remember this, because if some examiner is interested in asking, don't remember just few things for undergrad. If you say that the few of these and cubic scoring for hypothyroidism, I think examiner should be more than happy. Okay, cubic scoring, yeah, where it is point based, it is score based, like feeding problems 1, constipation 1, inactivity 1, hypotonia 1, and macroglossia 1, and patent posterior fontanelle 1.5. And typical faces like this coarse faces which we have seen previously, that is that has the highest score of 3, umbilical hernia 1, and skin mottling 1, and dry skin 1.5. Okay, all this constitutes around 13 points, and if there is more than 4 points of these 13, we may have to think for congenital hypothyroidism. Okay, apart from your blood routines and investigation, clinically this is a scoring system that should make us ring a bell regarding hypothyroidism. Okay, this is a pic of lingual thyroid. Okay, when you're opening the mouth, and if you're seeing something behind the tongue obstructing your view to the uvula and the pillars of tonsils, This is the lingual thyroid. Okay, this is just to sensitize you regarding the terms. Okay, yes, this is an interesting thing. Use just to see this is the effect of starting thyroxine at the right time. Okay, this is a newborn who presented with hypothyroidism. Then subsequently, the child was started with thyroxine, and you can see this course phase is the same child. Okay, this four pics are of the same child. The course phase is the crying child. Course phase is umbilical hernia and irritability. Okay, and then once the treatment has been started, you can see that resolution of umbilical hernia. The baby's face is like, now the baby's face is good, not coarse like before, and the baby is not irritable, like baby is okay with things. And now this is the close-up of the face. Just see the difference between these two. It's the same baby. Okay, I'm not doing Photoshop or something. Okay, same baby. See the face, the newborn's face, and now see this coarseness of the face of hypothyroidism. This is after supplementation. Okay, this is what timely management can make. Okay, this is the effect of it. Okay, yeah. Coming to the next topic, hyperthyroidism. This is relatively less in incidence and relatively uh, not much seen. Okay, this is a short presentation anyways, we are concluding soon. Yeah, by definition, excessive secretion, as the name suggests, if T4 and T3 are low, it is hypo, and T3 and T4 are high, it is hyperthyroidism. Yeah, affects the metabolic process in all the body organs, and hypothyroidism is 4 to 10 times more prevalent in women. Okay, and most common endocrine disorders only to diabetes. Okay, this is your Western stats, and the Western books say that. Okay, yeah, causes. They can be transient, like transient hypothyroidism. They can be transient hyperthyroidism, like neonatal thyrotoxicosis, and infectious cause like acute and subacute thyroiditis. As we discussed, subacute thyroiditis can present both with hypo and hyper. And drug-induced like amiodarone, interferon, and interleukins, they can produce hyperthyroidism. And iatrogenic, like if we give more iodine, that can cause hyperthyroidism. Now, all these are your transient causes. And persistent cause, like as such, the hyperthyroidism, it is the Graves' disease. Like congenital hypothyroidism is most common. Graves' disease is most common for hyperthyroidism. And you can find toxic multinodular goiter and toxic solitary adenoma, and central cause like pituitary origin, like pituitary adenoma continuously producing your TSH, and continuous TSH production hits the thyroid gland, and thyroid gland continuously produces T4. Okay, this is just like something like secondary cause of hyperthyroidism. Okay, remember Graves is the most common cause. Okay, see these nodules, mostly the multinodular nodules and solitary nodules, there will be mostly hyperthyroid. Okay, whenever there is a nodule or something that is extra to the gland, it produces more. Okay, remember like that. I think mostly you will be discussing this in your surgery actually. Okay, multinodular and solitary nodule. This is how this is where the importance of ultrasound comes. Okay, ultrasound finds your solitary nodules and multinodular nodules in the thyroid. Okay, coming to the neonatal thyrotoxicosis, occurs in 5% of thyrotoxic mothers. If the mother is hyperthyroid, mostly the baby can have transiently will have thyrotoxicosis, and severity is consistent in future pregnancy, and 20% mortality if untreated, because even though it is transient, we may have to intervene it because the effects are detrimental. Okay, and evolves rapidly and evidenced by day 7 of life. By day 7, you find all the features like your protruding of eyes and excessive diarrhea and all this stuff will be present. By 7th day of life, the baby will present itself. Okay, and associated with cranial synostosis, see, it is just like the fast forward of development. Okay, cranium will close, the fontanelles are delayed previously in hypothyroidism. Now the fontanelles will start closing early, and learning difficulties will be there, and all this can be present. And fetal thyrotoxicosis in rats produces abnormal myelination, and we are thinking that this is also be present in case of humans also. Okay, parents should be aware of the potential learning problems. Just tell them that in the future the child may be having low grades in school because the parents should be stressed upon because of there is a problem, so that there will be learning disabilities. You can't expect A's in case of such hyperthyrotoxicosis kids. Okay, coming to the most common, the Graves' disease. The pathogenesis is T cell mediated autoimmune disease, and it is associated with the HLA, A1, B8, DR3, DR4, DR5. An autoimmune disorder that results in production of antibodies directed against thyroid antigens like either the receptor or the thyroid globulin or thyroid peroxidase. Okay, all these things, the antibodies have been produced and they stimulate the overactivity of T4. Okay, that is the Graves' disease. And subacute thyroiditis, as we discussed, it is of infectious cause. Over weeks to months it can be present, and the acute phase can last for 2 to 6 weeks of a year with clinical and biochemical hyperthyroidism. Recovery phase may take few months, transit hypothyroidism, then euthyroidism. And clinically, history of sore throat, fever, tenderness, cervical lymphadenopathy, and on bloods, as it is an infection, you can find all the infective markers like raised ESR. And antibodies are negative because antibodies are present in your Graves' disease, and absent radioactive uptake. Okay, the gland itself is good. It is not extra gland or extra overacting gland. It is the gland itself, but it is getting sored up. Okay. And hyperthyroidism of significant mortality and morbidity and even death can occur in case of hyperthyroidism. And how they present is with shaky, tremors and nervousness, and difficulty in concentrating, learning disability, emotional liability, and insomnia. In hypothyroidism, they'll be sleeping. In hyperthyroidism, there'll be insomnia. They can't sleep properly. They'll be always active. And rapid heart rate, palpitations, and feeling hot. The sense of hotness will be there. And weight loss because high BMR. There'll be weight loss, diarrhea because increased peristaltic movement, fatigue, and in case of adolescent females, menstrual, there will be lighter flow and shorter duration. Okay, in the other case, it is high flow and longer duration, hypothyroidism. Okay, on exam, you'll find that eye findings of the classic proptosis and exophthalmosis will be present in 20% of the cases. The goiter may be present on palpation. And on auscultation, you may have thyroid bruit or thrill, and there is tachycardia, as we discussed. It is positive inotropic effect on the heart, and there is a flow murmur and systolic hypertension. Just remember, there is diastolic hypertension in hypothyroidism. There is systolic hypertension in um, hyperthyroidism. Okay, hyperreflexia, tremors, and proximal muscle weakness, clubbing can be present. This is thyroid acropathy, that is clubbing. It is mostly seen in the index finger. And onycholysis is a separation of the nail bed from the nail, that also can be present. And dermopathies, this is also an accumulation of the tissues beneath the skin. Okay, now coming to the Graves ophthalmopathy, you must be much aware because you are fresh from ophthalmology. The pathogenesis in infiltrative ophthalmopathy is poorly understood. It is before the onset of hyperthyroidism as late as 15 to 20 years of age. And the clinical course of ophthalmopathy is independent of the clinical course of hyperthyroidism. It doesn't mean that hyperthyroidism is more severe, so that there has been more ophthalmopathy. It's nothing like that. Okay. Infiltrative may result from immunoglobulins directed to specific antigen in the extraocular muscles or orbital fibroblasts. Okay, this is what they say, that there is antibodies that are produced, and there are, that is, and then inflammatory markers and infiltration behind the eyeball, the adipose tissue and fibroblasts that are present, that will cause your proptosis. Okay, the antibodies are distinct from those initiating Graves type hyperthyroidism. Okay, these are something different. Okay, the eye disorder, there will be lid lag and lid retraction and starey look, that wide open eyes look. And this is due to increased adrenergic tone stimulating the levator palpebral muscles to pull more the lid more up so that there is a big eye that we can see. Okay, and true Graves' disease where we can see proptosis, diplopia, double vision, and inflammatory changes like a conjunctival ingestion and periorbital edema and ecchymosis, that is swelling of the eyeball. And these are all due to auto antibodies which are against the fibroblasts, adipocytes, that is the fatty cells, adipocytes, and myocytes behind the ear, the extraocular muscles. That these constitutes your ophthalmoplegia. Okay, and coming to the skin manifestation, thyroid dermopathy, there is thickening and redness of the dermis. This is because of the lymphocytic infiltration beneath the skin. Okay, that causes the thickening and infiltration of the dermis. And there is the clubbing and acropathy that is usually seen in your index and thumb, but can occur in all the all the fingers also. Okay, and how do you diagnose? It is the TSH, which gets low, that is as low as 0.05 micro units per ml, and 95% of the cases there is high free T4 and T3, and 5% high T3 with the normal T4. And thyroid receptor antibodies are usually elevated, and antibodies against thyroglobulin peroxidase or both may be present in majority of the cases. As we discussed, it is the common cause of your Graves' disease. Okay, treatment is mostly you radioactive iodine, antithyroid, or surgery. This is the three main thing. It is there is no hard and fast rule. It is tailored to each case, and none is ideal or the best thing to do, and none interrupts the autoimmune process. Whatever you do, autoimmune process stays and goes on, and every modality has its own problem, and there is no treatment for underlying cause, and the cause has to be there, and the child has to suffer, and no other research options. As far as now, there is nothing much happening with thyrotoxicosis, though appearing depressive, but yeah, we may have to treat. Okay, radioactive iodine, antithyroid drugs, and surgery. In case of neonatal thyrotoxicosis, Lugol's iodine, like 1 drop TID for 1 to 2 days in a week. There is dramatic course, it gets decreased. Lugol's iodine is this iodine. Okay, blocks T4 release and synthesis and iodine uptake, that is Wolff-Chaikoff effect. And you can do propranolol and carbamazole therapy, but it will take some time. Okay, it is mostly Lugol's iodine in case of neonatal thyrotoxicosis, which is a dramatic effect. Within few days you will get the response. Okay, other drugs are beta blockers like propranolol, atenolol, and metoprolol can be used, and radioactive substances can be given with in Graves' disease. The dosage is 10 to 15 millicurie units, and toxic adenomas 20 to 30. Okay, and absolute contraindications in case of pregnancy and lactation, and if the female is getting pregnant, advise them not to get pregnant for 6 months after the therapy. Radioactive 131 is being used for therapeutic purposes. Okay, and antithyroid drugs are propylthiouracil, which is safe in case of pregnancy, and methimazole, which is 10 times more potent than propylthiouracil, so the dosage is 10 times low, so 100 for propylthiouracil and 10 for methimazole. And complications are granulocytosis, rash, hepatic necrosis, cholestatic jaundice, and arthralgia can be present. Okay, granulocytosis, remember this is important. In case of antithyroid drugs, we may have that. Okay, surgery, you do total, subtotal, or total thyroidectomy based on the condition and your surgeon's discretion. Okay, and you may have to substitute with the drugs subsequently. Okay, it is a permanent hyperparathyroidism. Along with thyroid, your parathyroid goes. Okay, you may have to supplement parathyroidism or parathyroid hormone also, and calcium maintenance also. Okay, recurrent laryngeal injury can be there, and permanent hypothyroidism can be present because you're removing the gland itself. Okay, that concludes the session. Yes, it is a bit faster, but yeah, we may have to conclude it. So coming boil down to the doubts and questions, if anybody is having any doubts, you can please point out. Hello guys. Guys. Hello.
No, sir.
Yeah, can you, do you have any doubts? Hello?
No, sir.
No, hey, no, can you see the slides?
Yes, sir.
Can you see this thank you slide now?
Yes, sir.
Okay, okay. No, no, because my screen that is visible has been blocked. Okay, no doubts. We can conclude the class. Okay, this is a bit faster, but just remember that hypothyroidism you have to give as early as possible, and the hyperthyroidism can be severe, but you may have to treat it. Okay, two things. Just you will find this in surgery. You will find the same topic in medicine, but the cause and concept is all the same. Okay. Yeah, if no doubts, we'll conclude the class because somebody is waiting, I think. Yeah, okay. Hello.
Yes, sir.
Yeah, yeah, okay. Thank you for your patient hearing. Yeah, thank you all.